that is Dr. Pallavi. Is she here?
Today I am going to present a case report of complete hand replantation surgery anesthesia management. Traumatic amputation have become in today's world of frequent travel, use of heavy machinery and practice of high-risk sport. Amputation of hand is devastating injury. It adversely affects the victim's ability to earn a livelihood, support his family and carry out daily activities. It also causes a great psychological impact on the patient and his family. In this case, replantation is the only viable option available. All replantation surgery should be treated as true emergencies where the time plays a key role. It requires a team approach by microvascular surgeon, anesthesiologist, intensivist and the support staff. Here we report a successful use of continuous supraclavicular block for complete hand replantation after traumatic amputation. Now coming to the case history, a 55 years old male patient ASA grade 1 sustained a complete traumatic amputation of hand at the level of wrist. He was printing press worker and sustained accidental amputation of hand with paper cutting machine. It was a guillotine type of amputation. Primary treatment with pressure bandage was taken from local physician and then he was transferred to the Noble Hospital for the further management. Patient reached our hospital after 8 hours of the primary injury. On arrival to our hospital, the patient was evaluated. He was hemodynamically stable but was very anxious. His amputated hand was brought in the polythene bag covered with ice. As we were informed in advance about the patient transfer, our surgical and emergency team was ready. Patient was evaluated by the microvascular surgeon and decision of hand replantation was taken. Patient and his relatives were informed about the advantages and complications of the surgery as well as about the anesthesia management. After informed consent, the patient was transferred to the operation theatre. This is the picture of amputated hand before surgery. Now coming to the anesthesia management, we elected to give brachial plexus block with catheter placement to carry out anesthesia management as well as for the post-operative pain relief. Supraclavicular block was given using under all aseptic precaution using nerve locator with 18 gauge B Brown contiplex set, that is needle with catheter set. After correct placement of the needle, 15 ml of 2% lignocaine, 15 ml of 0.5% bupivacaine and clonidine 70 mics was inserted. Then the catheter was inserted and stick was kept 5 cm beyond the cannula and secured to the skin with the micropore dressing. We observed rapid and adequate analgesia and the patient was comfortable during the primary preparation itself. Oxygen was supplied with mask. Intraoperatively, the patient was adequately monitored. He was mildly sedated with midazolam and infused with adequate crystalloids. Patient was kept warm with the Berheger warmer. Intraoperatively, single dose of anticoagulant was given and Dextran was started. Procedure lasted for 9 hours and it was uneventful. The first top-up dose was given with 12 cc of 0.5% bupivacaine after 2.5 hours. Subsequent doses were repeated after every 1.5 hours. Patient was pain-free and comfortable. The last dose was given with 20 cc of 0.25% bupivacaine with fentanyl and then he was shifted to ICU. While shifting, he was made aware of the importance of the catheter and the catheter care. This is how secured the catheter while shifting to the ICU. The ICU people were informed to monitor the pain score at regular interval. No analgesics were required overnight and next day the patient was comfortable but had mild pain. 15 cc of 0.25% bupivacaine with clonidine was given and same was repeated in the evening. On the second post-operative day, patient's record shows the average VAS of 2 and he was given 15 cc of 0.25% bupivacaine with clonidine. No top-ups required thereafter. Patient was happy about the pain management by the catheter and catheter was removed on the 5th post-operative day. The principal goals of the replantation of hand are to restore circulation and regain enough function and sensation to facilitate return to the previous employment and activities of daily living. Amputation injuries are broadly classified into 3 types based on the mechanism of injury: clean cut injury, crush injury and avulsion injury. Of these, the first type has the better prognosis for the functional recovery. Several factors affect the outcome after the replantation surgery. Post-operative arterial insufficiency is the most common cause for the replantation failure. It is suggested by the decreased capillary refill time, tissue turgor and temperature. One of the treatment for arterial insufficiency is the sympathetic block. Brachial plexus block is recommended technique in literature for the upper limb microvascular surgery. regional anesthesia has a definite advantages in microvascular surgery. It provides good anesthesia with sensory, motor and sympathetic block, prolonged regional block for surgical procedure and post-operative control of pain and vasospasm by all standard approaches. General anesthesia is another option, but patient has to face problem associated with the prolonged GA like hypothermia, accidental awareness, prolonged recovery time and so on. The most important advantages with brachial block is sympathetic blockade in our case. The sympatholysis interrupts the injury-induced vasospasm, provides maximum vasodilatation, thus increases the circulation and acral blood pressure. It also obviates the need to withhold the blood products needed for the coagulation. Sympatholysis inhibits sweating, thus diminishing the possibilities of the bacterial infection. Trauma and pain to the injured extremity causes the stress response, which adversely affect the coagulation and vessel size. This response is diminished with continuous peripheral nerve blocks. Additionally, patient remains conscious, thus reducing the cutaneous pressure injury as well as post-op confusion. Improved circulation, analgesia and suppression of muscle activity, all this contributes to the better healing after replantation surgery. Here in our case, we have used nerve stimulator to locate the plexus. Actually, amputated limb limits the usefulness of the nerve stimulation in confirming the needle placement. In our case, USG would have been the better option, but it was not available with our institute at that time because and the amputation was at the distal level, so we could elicit the motor response using the nerve stimulator. But for the proximal amputation, USG or the combination of USG and nerve stimulator was suggested. These are the pictures of amputated hand before and after the surgery. So to conclude with, in my opinion, continuous brachial plexus block is safe, reliable and useful for replantation and other prolonged operations of the upper extremity. The technique is well accepted by the surgeon, patient and anesthetist. These are some of the references. Thank you.
Thank you, Dr. Pallavi, for that presentation. I thought the case was extremely well managed. I have a question or two, but we'll discuss it later. Thank you. Again, in the interest of time, we move on quickly to the